When you walk into a hospital, you assume that the medicine you're given, especially something as basic as aspirin, is almost insignificant in cost. After all, aspirin is dirt cheap. Over the counter, a bottle of 100 pills can cost just a few dollars. But billing is not based on retail pharmacy prices. Instead, it's rooted in a world few patients understand, powered by a list called the Chargemaster, where hospitals inflate prices to dizzying heights, for everything, even aspirin. The Chargemaster is the starting point for hospital billing. It's essentially a gigantic menu. Every test, every supply, every drug, every procedure, they all have a standard charge. But these standard charges are far more than what the hospital actually spends to acquire the item. In the case of aspirin, the item may cost the hospital pennies. But when you look at that bill, it's being treated like an item in a high-profit product line. That $100 aspirin isn't about the cost of the tablet. It's about the markup mechanism. Why do hospitals do this? Because they can. Hospitals routinely mark up medicines by hundreds of % above what they paid. According to recent analyses, hospitals often charge patients at 500% or more of their acquisition cost for certain drugs. That's not just greed, it's a structural feature of how hospitals generate revenue. Insurance companies reimburse based on these inflated list prices, and for uninsured or out-of-network patients, that posted list price may end up being what they have to pay, unless they fight it. But it's not just about drugs. That same markup logic applies to nearly everything in a hospital. When the Centers for Medicare and Medicaid Services, CMS, finally required hospitals, starting in 2021, to publicly post their prices, including their Chargemaster, cash prices, and negotiated rate files, the hope was that transparency would force hospitals to lower their inflated prices. In practice, compliance has been spotty at best. According to watchdog groups, only about a third of hospitals are fully following the transparency law, even years after it took effect. Some of the largest chains, investor-owned systems, don't fully comply at all. When hospitals don't list full, clear pricing info, that lack of transparency creates a kind of power asymmetry. Institutions can charge whatever they want, patients rarely know what to expect, and they certainly don't know how to challenge it. High list prices feed the negotiation process with insurers, but for real people, especially those without insurance or stuck out of network, those inflated numbers can become a crushing reality when the bill arrives. Here's what's even more troubling. Studies suggest that hospitals with the highest markups are not offering better care. In fact, research shows that high markup hospitals, those that charge many times more than their cost, often have worse patient outcomes, including higher complications and readmissions. These aren't the scrappy community clinics. These are large, investor-owned hospitals in big cities. Charging 10, 13, even 17 times the cost isn't fueling excellence. It's driving profit, not value. To most patients, the system feels utterly divorced from real medicine. You go in for a heart attack, you take a little aspirin, but when you walk out, if you're uninsured or out of network, the bill is a luxury price tag. Transparency rules were meant to save people from that surprise, but enforcement has been weak. CMS is supposed to fine hospitals not complying, but as of the latest reports, only a handful have actually been penalized. Even then, hospitals are given months to fix things, and most do, not because they want to, but because they're forced to. No real reform, just a patchwork. And for the hospitals themselves, charging high prices for medicine is lucrative. A study by researchers at UC Berkeley found that hospitals retain a massive share of insurer payments when they mark up infusion or specialty drugs. These inflated margins become cash cows. Hospitals earn significant revenue from drug administration, so much so that mergers and acquisitions become more attractive. If they can administer more infused drugs at huge markups, they can justify expanding, consolidating, and absorbing physician practices, which in turn boosts their volume and pricing power. Patients, meanwhile, are left to scramble. If you're insured, part of that inflated price might get written off or negotiated down. But the higher the list price, the more your insurance is likely paying, which eventually drives up premiums. If you're uninsured or out of network, that $100 aspirin is just one more example of how medical debt builds. Small things can become massively expensive because nothing in a hospital is billed cheaply, even when it should be. The fallout isn't just financial. People go into hospitals with health crises. They shouldn't have to worry that their bill for a basic drug will haunt them for years. Medical debt is a real crisis in America. And in many cases, hospitals are using the Chargemaster to build a buffer, padding their revenue, shifting risk, and leaving patients with the burden. What keeps this all going? Several forces. First, there's no real cap on what goes on the Chargemaster. Hospitals are setting whatever list price they want, with little oversight. Second, there's strong incentive to maintain these inflated rates. Insurer negotiations happen from that high starting point, and cutting them too much might weaken a hospital's leverage. Third, transparency laws exist, but the ways hospitals comply, or don't, make the published data often meaningless to ordinary consumers. Big Excel spreadsheets, obscure files, missing negotiated rate data. It's all technically there, but not truly usable by the average patient. What's the fix? A few things could help. Stricter regulation could limit how far hospitals can mark up certain items, especially cheap, common medicines. Better enforcement of the transparency laws could force full compliance, not just check-the-box disclosure, but real, consumer-friendly pricing. And reforms to payment models could steer hospitals away from profit by markup and toward value-based care, where compensation is tied to outcomes, not list price games. For consumers, the best weapon right now is information. Check if your hospital publishes its Chargemaster in a readable format. Ask for itemized bills. Challenge surprise line items. Advocacy groups and price comparison platforms are building tools to help, but they can only do so much when the system itself is stacked against transparency. Back to that aspirin. It was just one pill, but its cost tells a story. It's a story of markups, hidden lists, and a pricing culture that treats medicine as a revenue source, not a public good. Until hospitals are forced to meaningfully open their books, not just in theory, but in a way that patients can truly understand, these $100 pills will continue to be part of a system that quietly overcharges those who are least able to pay. And until that changes, every little white pill could come with a shocking number.